Very good. Thank you so much, Casey. Well, good afternoon, everybody. I'm Carl May. I'm a sociologist at the School of Hygiene and Tropical Medicine. And Casey's quite right. I've been sort of hanging around on the periphery of Care Unit for close on 13 years now. I'm going to talk about some stuff that has really come to matter to me quite a lot. And in part, that's because over the past 20 years, I've had to see all of my parents and parents-in-law through quite complicated and difficult medical trajectories. And that has made me think very seriously about the way in which we think about treatment burden and the way in which we think about innovations and implementation. And Casey's quite right. There is a paper that is kind of somewhere that sort of came into existence, perhaps as a torrent of complaint about some of the features of contemporary healthcare. But I want to go back to our first minimally disruptive medicine paper, and we presented a clinical methodology that puts the patient at the center of their care. And so one of the questions that I'm interested in, so that paper is May et al. 2009. It's the original burden of introduces the concept of burden of treatment and develops ideas about minimally disruptive care. And then the question is, well, what stands in the way of realizing care that fits? And that's the question I think that all of us are asking right now. I want to start by saying, well, care that doesn't fit is actually structurally generated with the best of intentions. Healthcare systems and healthcare providers work very hard to deliver healthcare, and most of them, I think, do so with very good intentions and a real moral commitment to their work. And yet somehow all kinds of what I'm going to call incivilities appear. Some of these are systemic. So I want to start with the idea of complexity and just say nothing is simple in the care of the patient. Nothing. The patient becomes enrolled into big, complex organizations, some of which they actually work their way through, but others where they don't. Perhaps we never see the pharmaceutical industry that has constructed our treatments, or we never see the financial services sector that makes different kinds of care possible or impossible. But what we do detect, I think, often is an almost unstoppable torrent of initiatives and interventions and projects and policies that seem progressively to make the business of healthcare more complex and more complicated. So the difference that I'm getting there is between lots of different things interacting with each other or connected with each other that it's difficult to trace a pathway through. That's complicated. And things that are dynamic and emergent within those structures, and that's complex. Healthcare systems are subject, I think, to all kinds of constraints, but the really key thing here is to say, well, actually, healthcare systems are huge. We sometimes talk about how difficult it is to turn the oil tanker around on the ocean, but here we're looking at things that are even greater than that. We're looking at, when we look at the American healthcare system or the British National Health Service or Germany or Canada, it's almost as though we're looking at plate tectonics at work, at changes in the geology of the earth, slow, obdurate, subject to tremendous inertia. Nobody wants it to be this way. Everybody wants healthcare to be dynamic and engaging and delivering. But even very small changes in a healthcare system can be hugely disruptive. So I sort of start by saying, well, care that fits is made difficult by the obduracy of large institutions, of mega institutions that need to look and feel alike so that they can maintain integration with each other, and that they must share the direction of travel. So all of this becomes interesting to look at if you're a policy analyst or interested in macro level events. But for patients, there's something a bit more complex going on. We experience uncertainty and fragmentation at almost every moment. And yet, at the same time, our pathways through care are often increasingly structured and inflexible, and our relationships with clinicians become uncertain. So an important part of that is that these big obdurate organizations actually generate healthcare inequalities at the same time that the people that are working for them fight them. So systemically, inequalities are generated. And with colleagues in the UK, as part of the Experts 2 study that I signalled earlier on in the acknowledgements, we've been trying to understand what the different kinds of inequalities that people face are. And these matter tremendously because they generate work for the patient and caregiver. So, I mean, we've got a very simple model here of the work that the patient has to do, and it becomes really, when you look at how much stuff there is going on in the life of a patient, and how much of what they do is actually about trying to mobilize healthcare systems in their favor. It's a tremendous amount of work. I saw Casey's slide earlier on that suggested that 40% or so of people find the burden of healthcare too great to carry, and I can easily see why that is. My argument is always going to be that care that doesn't fit isn't inevitable. It's not a natural phenomenon. It doesn't appear in nature. We create healthcare systems, and so we can change them. And the great impetus of the work that many of us are involved in is trying to find a way forward to sometimes break the chain of obduracy and to explore ways to create systems that are patient-centered. So this is if there's anything you take away from my talk, it's this slide. It's not inevitable that care systems are produced that don't fit the wants and needs of patients. Everything is modifiable, even if it's very difficult. So how can we think about reconstructing the kinds of things that healthcare systems provide? Well, a lot of my time is spent thinking about the implementation of healthcare innovations and the development of services in which they might sit. And one of the things that I think is that confronts everybody who tries to implement these large, complex interventions, whether they're clinical trials or whether they're new care pathways or new clinical services of different kinds, is that what we lack are really good principles for design. And I and Victor and Francis Mayer, who you're going to meet in a moment, have sort of been batting around a set of what we call micro principles for service development and design. And we call them micro principles because small miracles are easier to achieve than grand designs. So here are 4 qualities that we could try to embed in services or complex healthcare interventions. Civility. How important it is to have kindness in relations between health providers and users. And the importance of civility rather than communication skills or interaction strategies is that civility is a moral thing. It reinstates the moral meaningfulness of healthcare work when people interact with each other respectfully. The second thing is simplicity. One of the extraordinary features, I think, of healthcare systems is how complicated they are for the user. And that's true of patients, of caregivers, of health professionals of different kinds, and health system leaders are confronted with enormous complexity all the time. A little bit of work to simplify things goes a tremendously long way. We can encourage clarity of purpose and ease of navigation. And most importantly, that leads to continuity of care. We know that those things matter a lot to patients. We know that patients and caregivers struggle sometimes to simply understand the system. Because we're all interested in burden of treatment, we're interested in subtraction as well, taking things away. And here's the really interesting thing about healthcare systems. We add to them constantly. We never take things away. We never reduce the low value, we never remove the low value components of the service. They sit there quietly, making things ever more difficult. So subtraction is an important micro principle. When we subtract from complex healthcare systems, we reduce workload. And when we reduce workload, we restore agency and capacity, not just to patients and caregivers, but to professionals and managers too. The fourth of those micro principles is dependability. I found it remarkable in my own experience of healthcare, not just in the UK, but elsewhere, how often people are uncertain that they can depend on a clinic, on an individual doctor, or on a service. One way that we can solve that is to rethink the number and density of components in a service and the number and density of interfaces between them. When we do that, we can eliminate opportunities for systemic failure. And it's systemic failure that makes health services difficult to depend on. So these are like micro principles for service development and design. But stemming from that, we need to have a little think too about what intervention components are like. And over a long period of time, I and colleagues have been trying to develop implementation models that are about more than trying to understand evidence translation. We're interested in what are the components of interventions. Well, obviously some are obvious to us. So we take ICANN for an example. There are objects and procedures that ICANN presents to us. So we have a very effective web-based interface that I've just used for the first time, and it was very easy. It alone, as an object and as a procedure, meets the requirements of Darwinian simplicity, by which I mean the survival of the easiest. But it also brings out some interaction strategies. And this is the interesting part that I just experienced while I pretended to be a patient with Anne actually being a doctor. She's not pretending to be a doctor, she really is one. And how those interaction strategies revolved around a set of assumed capabilities. So in the clinical consultation, with any new development, whether it's ICANN or a shared decision-making tool or a web-based portal, whatever it is, we have to assume a set of capabilities on the part of the user. It's worth thinking hard about how we make those assumptions and how we fit them to the objects and principles, the objects and procedures that people are using. And of course, when we introduce any kind of tool into doctor-patient interaction, of course, we just change things just slightly in the way that people become accountable to each other. And we change the rules and resources that are available to people. Now we say, well, using this tool will direct you in a particular, to a particular end. Using that tool will take you somewhere else. And this, I think, is exciting and interesting stuff to investigate. But it's also important that we take these things actually into account when we're designing things. When we design a tool, we simply don't design the interface between persons. We're assuming a set of interaction strategies that will emerge around it and a set of rules and resources and accountabilities that will come out of it. And of course, we also assume an organizing logic to everything, and that gives cognitive authority to us as we use and mobilize an intervention. And it also gives meaning to our actions. The organizing logic of ICANN is to bring into view things that matter. And it assumes a cognitive authority on the part of both the patient and the clinician. And it assumes a set of informal agreements about the values that will matter to them. So I find ICANN is a really good example of something like this. It was my intention to talk about a completely different tool, clinical tool. But I was quite excited by using ICANN. And this brings us, I think, also to think about implementation outcomes. When we think about services or complex interventions, we inevitably think about performance. Did it work? What has changed? But actually, all of these things, all interventions create changes way beyond the actual sets of practices that we're investigating and measuring. So one thing that happens is relational restructuring. So how does that change the way that people are organized and relate to each other? So ICANN changes those relations by revealing things that are important about life, rather than things that are visible around symptoms. And if we reveal things that are important about life, we profoundly change the doctor-patient interaction. It becomes about something more than illness. And then we also see profound normative restructuring. All I mean by that is how the rules of engagement change, how the things that we say ought to be are reformed. With ICANN, we're saying we ought to look at something more. We ought to look at the load that people carry. And of course, because I'm who I am, the big question that I always ask is, if we're thinking about an implementation outcome, how about sustainment and normalization? How have interventions and their components become incorporated in practice? How have they become or not become deeply familiar parts of work? So I kind of laid out 3 different ways of thinking about service interventions. I've set out some micro principles for service development and design. I've set out a framework for examining intervention components. When we offer people an intervention, what is it that we're actually doing? And I've set out some implementation outcomes that we can look at and say, yeah, this is how our ICANN, for example, is changing the way that clinician and patient interact. And so to briefly conclude, so first of all, some of you who know me know that I have a deep love of boxes and arrows. And so here are some boxes and arrows, but it's important to think about what sits between the boxes. Being able to distinguish between these components of principles for design, the content of intervention, and outcomes of intervention is useless if we have no way of learning from them. And so at every stage, I think we need to consider the lived experience of their users, both patients and caregivers, and professionals and managers in healthcare systems. And we need to think about how those lived experiences can be incorporated in translational design. And of course, we need to have systems that learn and reinvent and reconfigure their services to make best use of themselves. So where does all of this Darwinian nonsense come from? Well, I'm saying it's possible to create care that fits people rather than people that fits care. And I've already signaled that I'm playing a little game with the Darwinian principle of survival of the fittest by saying that survival of the simplest and easiest is actually what we're after. But I also want to make a point. Stephen Jay Gould, who died 5 or 6 years ago, was a really great evolutionary scientist, and I think the only evolutionary scientist to have appeared on The Simpsons. And he spent 40 years investigating the evolution of mollusks. It's a great way of spending your life, but he was able to parlay that interest in fossil shellfish from the Jurassic and Cretaceous period into a remarkable insight, which is that evolution happens at the margins. And that's where the kinds of changes that I'm talking about are likely to appear, at the margins. And just as particular kinds of bivalve came to dominate the world, so I think can tools that are respectful and civil, that reduce workload, that take care of people's hopes and wants and needs. I kind of feel very strongly that we have tremendous power if we don't try to situate ourselves at the centre. So thank you all very much.